if you are here, you know that you're not here to see me. You're here to listen and watch Marianne spew golden truth regarding revenue cycle management, coding, and billing. Marianne really requires no introduction. She was the billing director of PRS Network, also known as the Painters. She's been recently upgraded to the role of Chief Operating Officer. When she first started with PRS Network 19 years ago, they only had about 8 employees. Now they have over 160 employees. They have grown tremendously. And what PRS does, they do a lot of things. And one of the things that Marianne does is she travels around the country helping other urology practices maximize their operational efficiency when it comes to coding, billing, and revenue cycle management. As always, you're joining us live. If you're watching this live, please feel free to leave any questions or comments in the comment section. I will ask Marianne as the show progresses. Without any further delay, welcome, Marianne.
Thank you for having me.
All right, the floor is yours. As always, I have no set agenda. Why don't I let you set the table and discuss what it is on your mind as you go across the country helping urology practices? What are the current hurdles and conundrums?
Well, thank you for having me, just first of all, and thank you for everybody who's listening and who reaches out to me on a daily basis for questions and PRS as well. We're here to help you guys, and we've really been in the industry lately helping practices maximize not just their revenue, but the efficiencies, as Dr. Lynn said, in the whole entire practice, from the start of the patient scheduling their appointments all the way to the patient possibly, collections and possibly going to collections to resolve that account. So as we're traveling around and answering your questions and getting on different conference calls, the biggest thing this last couple weeks has been the Humana debacle that many of us are facing with the automatic downcoding that Humana is doing at the current time. These are problems that you may have seen or you will see, or maybe you haven't noticed yet. But I'm strongly recommending that you guys go into your Humana remits, whether you have a small population payer mix of Humana or a large payer mix of Humana, and look at those remits if you have not done so already, and look at your level 4 and level 5s, both established and new patients, and view your explanation of benefits and see if they are downcoding those services to level 3s. You should be seeing a code CO 150 or CO 131 is currently what we're seeing on the remits. However, we've seen practices that auto posting or manual posting has missed those adjustments being populated to a denial. So if you, for example, if you are seeing that the posting is there and the system does the math, there's $20 going over to the patient, they may write off that additional amount from your original level 4 to what they're paying you at the level 3, and you may not see it. And we are seeing several older systems that are actually, the practices did not know this was happening.
So you're saying Humana is automatically downcoding level 4 to level 3 new and established patients?
Correct. With the advice, the remittance advice code stating that it doesn't meet the criteria, the records don't support what was billed. However, they didn't get records. So we're seeing dates of service over, just over 7 days ago being on the remit, which they never requested records, but it's an automatic down code on level 4s and level 5s.
And when you and your team inquire through Humana, what did they say?
They're stating that the remittance advice was correct, that was downcoded because the documentation didn't support. We're letting them know that we did not submit documentation, and they are now stating that that is up for appeal.
Okay, that is extremely frustrating.
It is. It's in the hundreds.
They automatically downcode you, yet they don't look at your medical records.
Correct.
How do you mitigate? How do you fight against this?
Well, we are still researching what we can do. Some clients, some practices are looking at possible legal ramifications through the contract right now. So we will keep informing you guys if that's a pathway to go. Right now, we are appealing every single one of those claims, and that is a very big lift on the billing and billing department in a practice, because that is taking people away from their regular tasks and their regular RCM duties, follow up. But right now, we are actually reviewing every document, and making sure that it fits the level 4 or level 5 before we're appealing. We're also looking at different avenues for possibly, if we had a provider who's had been audited in the past and has very good coding, possibly go ahead and appealing those. If you guys have a large volume and you're not able to get through that, going ahead and appealing those with the knowing that that provider is a good coder, getting those ones out, and then reviewing some of your providers that may not be as good of a coder or might be newer, a physician's assistant that might be newer, and that might speed up your process as well a little bit. But right now, you need to appeal them, and I'm strongly suggesting not to just take that down code, because if we allow them to do that, we're also seeing that. I know a lot of people who are probably listening are saying this is happening with Aetna. This is happening with some Blue Cross Blue Shields across the country. And if we continue to allow them and just accept that, then what we're doing is allowing them, as I always say, they're winning. And unfortunately, we're putting in the work to get that done. But hopefully we can all come together in some sort of way in the future and battle Humana against this.
So whether that is class action lawsuit or simply working your practice and making sure that you are being properly paid. So what I'm hearing you say is that so they do this automatic downcoding, not denial, but they automatically downcode you 4, 2, or 3. You are advising your clients to not just send the medical records on every single one of these downcodes, but instead look at the medical records to make sure that your claim justifies a level 4 or whatever level that you build. On the other hand, if you have well-educated, coding-wise physicians, urologists, those claims you would just say, okay, without additional review, go ahead and send those medical records into Humana and Blue Cross and appeal those.
Correct. If your volume is there where you're trying to figure out how you're going to get through the hundreds of denials that you've received for this, that is a pathway that I would suggest you might want to take so that you guys can get those out in a timely fashion, because of course you've got to appeal in a timely manner to them or you lose out as well. So in those cases, when you are having to make some decisions, if you do have those strong coders, like if I had you, Dr. Lynn, as when I would probably send your records through without review, but maybe take a new PA that I just had in here and review those before I sent out to make sure that we don't get additional denials for that PA once they get those records. In turn, twofold, always killing two birds with one stone. Use that as an opportunity to audit. If you're going to audit them anyway, use that as an opportunity to give that feedback to your providers. Because if you're going to have to review 100 files anyway, you might as well make that your audit, your compliance piece, because you are going to put that through and go ahead and check your providers and get that feedback back to them, because you're doing that anyway in your practice a lot of times. And that's one of the suggestions that I have, is that you take that piece, trying to compensate for the work that you have to put in for this, and trying to lessen a load on another piece to make sure that this doesn't burden your staff too much.
Yeah, using that audit or the chart review as part of your compliance protocol program, instead of just doing the review just to fight against these automatic downcodes.
Correct.
That's
and this
insane.
is a lesson to everybody. I see this often. We are seeing this more and more. And we are also seeing practices who don't know this is happening. This is a good chance to review, put in, I know monthly is possibly an overload on staff currently, but on a quarterly review, pulling your payers and looking at these things to make sure that you're getting reimbursed correctly, because we have seen practices where this was going on for a couple of years and they did not know that, and now they're fighting that years later, and they may not have that financial recovery that they needed because they did not review it at the time or send in an appeal.
Very good. I'm just looking at the comments and making sure that we are not missing any of these valuable insights or valuable comments. Okay. Very good. Looks like we're caught up. So as usual, if there's anybody in the comments watching this live, please feel free to ask any questions.
Yes.
Or if you have any insights, please share those.
Yes, and in turn, just make sure you guys have a policy to look for this stuff. It's going to keep happening. We're going to keep seeing this. We're going to see the denials for the 25 modifier with procedures. Keep fighting with the appeals. Keep reviewing your records. And like I said, try to maybe use those records that you're having to pull and those appeals that you're having to do for a review and audit for your providers and feedback so that you can give that back to them. If you're doing the work anyway, you might as well give that feedback back to them.
Yeah, sounds like a great idea. What
Yes.
else is going on that you're seeing across the country?
On top of that is the extreme amount of records requests from the providers or the payers that we are seeing on your providers, which has also been a huge taxing event on staff, on our staff as well. And I just want to make sure that you guys are really making sure that you have a process. It is good to have a medical records clerk that sends out records, and I understand that process. I just want to make sure you guys have that person, whoever is sending out records, whether that's a medical records clerk or your AR team, your accounts receivable, your front desk, whoever's sending those out is educated to be able to send out the correct records. What I mean is that if you guys, for example, I've seen time and time again, if you have a urodynamics request and you only send out the office visit and you do not send out the results of the urodynamics, you will have a denial on that claim and you will have a possible recoup if they have paid anything on those urodynamics because you didn't send in the records for that. If you have a procedure that is done in the office and you only send the E&M notes and you have the procedure on your claim, you need to make sure that your staff is really educated in what needs to be sent and the full documentation. On that same note, not sending too much information. We have seen practices where it's like, let me just send the whole chart. Let me send the whole, shebang of information. You don't want to give the payer too much information either.
Well, in
So-
essence, you want to make it easy for them to adjudicate your claims properly. And that's what my biller does. She will highlight, circle, and say
Yes.
asterisk, and here, look, dummy.
Yes.
This is what you're looking for.
Correct.
And not just send a logorrhea of just a bunch of records. She just sends the specific record that they request,
Yep.
highlighting the area that they need to look at to justify why we're right and they're wrong.
Correct. And in that turn, we've also had our staff circling the staple of a claim if we've had to mail it, because then when they tell us there was no attachment, we're like, whoa, wait a minute. Can you look at my claim? Because there's going to be a circle up in your top left-hand corner where the staple was. Can you go ahead and find that attachment for us?
I love it.
And so I really want to make sure you guys are realizing that sending the correct information and complete information is very important, because remember, when they get that on the other side at the payer's end, if they start seeing that they're not getting that from you, they're going to most likely start pulling more of those claims from you. So they're going to start requesting more records on something if they know they're going to recover money from you.
And on the other hand, are you seeing any of the things that are happening? Say you keep sending in records, you keep getting those denials overturned. Are you seeing that they're requesting fewer records?
Yes. So with that, we've talked about this a couple of times in some of our seminars or some of our discussions, Dr. Lynn. When you guys appeal and you guys are winning those appeals, don't be afraid to call your payer and start stating, wait, just make sure you realize, hey, you guys have requested 100 of these. We have not lost one appeal on these. Why are you continuing to request these records? Don't be afraid to call and ask why you're requesting these for everything. And most of the time, we've had experiences where we've actually gotten on the phone and they've said, oh, well, actually, this doctor was supposed to be removed from this list, and we will go ahead and remove them. But those phone calls are valuable, and also in turn, sometimes the payers do it automatically. They will pull back and stop requesting those on several of our providers that are, we're just not losing on those. We've seen a lot less requests on the urodynamics. We've seen a lot less requests on urolifts because we are sending in those appeals. And also, I have a couple people on my staff. Donna is not afraid to call and just sit on the phone and wait and say, why are you asking for this data? This was wrong. And a lot of times that turns out to be a positive thing on the end where we end up having less work because they're like, yep, you're right. We shouldn't be pulling these anymore.
Unfortunately, that takes a lot of work.
Yes.
It's a time suck. And I'm not sure if all the practice, first of all, they may not know to do that. And number two, they may not have the resources to have somebody set on the phone just to educate the payer and say, hey, get us off of your list to pull records and request records every single time.
Correct. If you have the resources, you can. If you don't, then you're going to have keep having those records being pulled. And remember, again, like I said at the beginning, take that as an opportunity. I know a lot of practices that we've been into and currently have coders who possibly are working in the AR space or maybe at the front end during looking at charges. Think about maybe reorganizing that a little bit and taking the opportunity with all the work that we're getting from the payers and the insurance companies. Maybe that coder needs to be in the space of this where you are having them review the records. You put them in that for the audit space, because then again, like I said, you're killing two birds with one stone. You're maybe putting them into a space where you can actually use them on the AR piece, on the accounts receivable for the appeal space, but also that coding auditing space. There is a lot of work that's being done in the RCM space right now on coding and submitting records. Use that piece to your advantage and maybe take the piece that you're doing at the front end and really have them help you on that back piece and tie it in with an audit. Because I will tell you, I don't think that this is going to get any easier. I think that Mark and I have talked a lot about AI recently because he's pushing me on the AI and that's coming. We're going to see a lot of AI being put in place, and that AI tool is going to pull even more records for us. I think that that's going to prompt a lot more requests to us as they put in AI and have specific check marks that we don't meet on the claim. That's going to prompt more records pulls, I believe.
So on the front end, they will just do the automatic denial, run it through some sort of artificial intelligence. And then I also think of this on the back end. Once you submit records, they can also have a machine interpret what's been submitted and then program or teach it to look for certain key phrases and key things. And if it's missing, it can spit out an automatically response and say rejected because of X, Y, and Z.
Correct. Let me give you a scenario that, was probably not AI, but I believe that it might be in the future. We're seeing rack audits on Xiaflex, for example. It's on an increase lately. And we have, we sent in the records. There was an addendum done to report the waste. And they came back and denied that record, stating that it still didn't meet the units that were billed in the records. Their statement there was that the addendums are meant to be done if the information is not available to the doctors at the time of the visit, if it needs to be added later, and that because we added it after the request. However, when we're reviewing this, and Mark and I we're all talking this out, we know Xiaflex has a certain amount of units. The amount that was given was reported, so automatic math would calculate that waste. So that's what we're going back with. But some people would take that as, okay, we lost that appeal, we're going to get that recouped. Just remembering that just because that verbiage is coming in there, that is also what we think AI will be doing. Exactly what you said, is that they're going to look at key phrases, they're going to push that out in policies, and people are going to get that and maybe not understand that there is a loophole to maybe keep appealing that. So we're going to go back and say, actually, the documentation was correct. The doctor is making addendum to make it clear what the waste was, but you can clearly interpret what the waste was by taking the amount that the Xiaflex has, what we administered, and what the waste was. But it is interesting how this is happening and how we will see AI develop in both the billing space, the coding and billing space, and the RCM space, but with you guys as providers on that front end piece with your EHRs.
Yeah, definitely, for sure. And I'm just reading, somebody said, circle every single time on the staples and things like that.
That was probably one of my team that's sitting there. We highlight exactly what you said your biller does. We are to the key phrases that we're talking about AI will do, that's what we're pointing out. Here's where this is stated by the doctor about the UA. Here is where they're stating about the cysto. Here's where this separate and identifiable item is here, where which supports a 25. We're putting that in there because you have to remember on that other end, oftentimes those people aren't educated in that space.
Yeah, it was Monique who said highlight and circle every time.
Yes, she is big with the Eurolift appeals and sending in data. I mean, the appeal process, which is also what I want to talk about today. You know, we are seeing a lot of education that is lacking in the revenue cycle management space. And when I say that is that we are all trying to get through the work that's been given, and we're getting a lot of denials from payers that we may not be understanding. And we're trying to get through the work. So therefore, rebilling the claim is often a reflex that we do. We just hit that rebill claim, we get that back out to the payer because we're like, we don't see what's wrong. I want to make sure you guys are really paying attention to what those denials are and that you really know the pathway that you should take. When a claim is denied, for example, for maybe a missing modifier, or you're going to change the order of your diagnosis codes, that is a corrected claim that you want to submit. That is making a correction in your system, highlighting if it's a payer other than Medicare with your 7 as a replacement claim on your claim, and resubmitting that through your system or through your clearinghouse back to the payer. That's a corrected claim, an item that can be corrected on your claim by adding or subtracting an item on your codes or ICD-10s and sending that. That does not need to be an appeal. I want to also say why I'm going through this whole series here in just a second. The next stage is a reconsideration. A reconsideration is when you're going to that provider or that payer, and you're going onto their portals usually, and you're asking them to reconsider why they denied the claim. Because maybe they're denying it as this is bundled, and you want to let them know, actually, no, this is not a bundled item. This is an item that can be unbundled and processed. You're filling out their reconsideration form and you're sending that through their portal and you're letting that go through. The last part is an appeal. An appeal is really the part where you know that it's not a correction that needs to be made. It's not something you do want them to reconsider, but you need to give them details. So this is the end step. This is one where the appeal is really where you are telling that payer and you're giving them the details of why you disagree with their decision. Medical necessity. You're disagreeing that they're denying this for medical necessity and why. So you are not, an appeal is not something, if you consider an appeal that says, please just reconsider my claim, and because it's on a piece of paper and you're sending it in, that's an appeal, that's not correct. That an appeal should be something that you're supplying supportive data to, and you're giving them a little bit of a who, what, where, when, why, and how of how that claim is, and you're documenting that for that payer. The reason I'm stating this is because we're seeing a lot of efforts being put out on what we're considering an appeal, and you don't actually need to appeal it. You can do those first things with the corrected claim or reconsideration. Your appeal should really be something that you guys don't have a lot of, unless it is necessary for you to give information and supporting documentation and write a story to them. You don't want to just print a claim and send a letter that says, please reconsider my claim. And you don't want to attach records. And that's because you do not want to give records to the payer that you don't need to. You want to make sure that if you can do a correction, you're doing that easily. That takes the lift off of your AR department. And if you're having to do reconsideration, you're getting that done very quickly with the form. And your appeals are really that part where you're doing 25% or less. And if you're having more than that in what you consider an appeal, you should really look at that process, because we're really spending a lot of time writing something, and it is actually really overloading the billing department.
Sounds like you're saying if you need to interpret, the RCM team needs to understand what is missing. And
Yes.
Instead of doing the extra work of going through an appeal, sometimes a simple correction and reconsideration is all that's needed. And that seems to be easier than having to print records and circle and put arrows on things for
Yes.
the formal appeal.
for the formal appeal. Formal appeals are for when the down coding from Humana. That's going to require a formal appeal. You needing to add a 25 modifier to a claim, that's a corrected claim or possibly a reconsideration. Really understanding that is really going to help speed up the process. It's kind of like if you were having to make AR calls, you're able to go on the portal to check claim status. You do that. You highlight the items that you're going to have to call your payer and do those all at once. If you're calling every single time, you're going to be spending a lot of time on the phone and you're not going to be able to get through a lot of your work. But if you can prioritize and really know which steps need to be taken and which pathways, you're going to get through your aging a lot faster and your claim status is a lot faster.
I know you are stateside. All your entire team is stateside. I always wondered those offshore coding and billing people who are not intimately involved with the daily operations of a urology practice. How are they able to, possibly they are or they're not, how are they able to do this job? Because it requires a really good grasp of the English language, really good grasp of the clinical aspects of urology, and then be able to integrate these two to be able to come up with a reasonable solution for appeals, reconsiderations, and corrections.
Yeah, I agree with you. I constantly am asking that question myself as well. It is good for example, they in my experience, it might be good in that process to just check the initial claim status at 31 days. That's where I think that a company like that might be valuable. Where I see the struggles, and actually personally have dealt with those struggles with companies of such, then it is definitely, you can get through that volume. I can make notes. I can get 100 claims in front of me and I can make those phone calls and I can get the answer from the payers on the other end. But anybody who's listening now or going to listen later to this is going to know, if you have made calls to those payers, if you just accept their answers every time, it is just as if you're getting that EOB and accepting that EOB that Humana sent to you and downcoded your claim. If you are going to accept exactly what they do and you don't have that knowledge behind that, you're not going to challenge them. Because I've been on a number of phone calls where I said, actually, I don't think that that's correct. Can you please look at this policy? Can you please look at this? And then when you're challenging them, they say, okay, yes, I'm going to go ahead and send this claim back for escalation and get this claim paid. You don't have that knowledge. You are going to accept that answer. And of course, you're going to put that note in the system. And that same company might come back to you guys as a practice and say, this payer is not going to pay this code anymore, so you need to stop billing it or you need to write it off, without that knowledge of the background to say how we can get it paid.
Yeah, when you should be paid, and sometimes because of lack of understanding of the billing and coding folks, wherever you outsource it to, they may come back and tell you that it's not being covered and you should stop billing for it, when in fact you should do the opposite. You should continue to bill for it, and it's actually up to the coding and billing team to educate and redirect the insurance companies, the payers, that you are correct and they are wrong, and you should be paid.
Correct. And, again, what we say is, when we're allowing them to win, and I do get, we're facing the Aetna right now denying UAs. We have come up with a couple workarounds with that to be able to place the 59 modifier on the UA, and then they still deny it. And is the ROI worth, what you say, is the juice worth the squeeze? Is the squeeze? What do you say? The juice worth the squeeze?
Is the juice worth the squeeze? Yeah.
Yes.
How much work and effort are you going to make to get a $2 or $3 reimbursement for a UA?
Correct. And you really do need to look at that part too. But you also want to say, if you are doing that on almost every patient, it may be worth that. And it might be worth it in the fact of just being able to make sure that payer pays for that service. Oftentimes, we've also found that the billing staff has said, okay, that we're not going to bill this anymore. And the providers are under that impression, they stop billing something. And we've noticed that it's just, if you just simply put an item in your notes with the results of the PVR and highlight that, when you send that appeal back, you get paid for that. Or sometimes you're just not putting the right diagnosis code attached to it, so you've stopped billing it. We've seen that a lot with labs, with a lot of PSAs, just not understanding that process. And going back to what you were saying before, really it's knowledge, not just in your office, but really just having your RCM staff reach out and get more knowledge, listening to items like this, podcasts that the PRS has, Dr. Lynn going and speaking at conferences, those education points really do come back, and even if you get one piece of information from us, you're able to maximize your revenue in a different way.
Yeah, so what you're talking about are these two PRS networks, Urology
Yes.
Advanced Coding and Reimbursement Seminar that are held once in December, typically in Las Vegas, and then this year, actually in 2026, in January, it'll be in New Orleans. If you want to sign up for it, learn more about it, go to prsnetwork.com.
Yes.
That is where you will get a condensed, just impactful, a ton of information about what Marianne is talking about today. And also Mark Painter will be there. I will be there. Scott Painter will be there. And sometimes Ray Painter will be there. And what is even probably more important, a lot of your colleagues will also be
Yes.
there sharing what they're experiencing in the trenches so that you can learn from each other. We can learn from each other
Yes.
and implement. I find some of the biggest and the most impactful nuggets come from the audience, come from the
Yes.
attendees.
I mean, I think that's where I'm constantly learning as well. People are emailing, reaching out, and then we find another nugget, and then another piece to actually put into the puzzle to possibly help us on the next appeal, on the next process that we're going through. It is, you guys have new technologies coming out in urology, and they may be unlisted codes. If we don't fight the battle on those unlisted codes, and send in the records and give the supporting documentation, if we don't do that, then that product may not survive, or you might not get reimbursed. But we're part of that, and sharing those pieces of information with each other on how you guys submit that information, how you got something paid, is how this community is surviving.
Yeah, and exactly to your point, what you mentioned about the Aetna UA requiring sometimes
Yeah.
modifier 59, Blue Cross Blue Shield in the past sometimes required modifier 25. So did
Yes.
Aetna. So 25, 59, neither are really correct, but sometimes that's what you have to do with these private payers to play the game, if you will. And
Yes.
guess why I learned about that? At one of the UACRS
Yes.
meetings many
Yes.
years ago. And I'm thinking, oh, we actually can get paid. Let's attach these
Yeah.
modifiers 25, 59, even though you shouldn't need it, but some of these crazy payers require it so you can bypass their edits to be appropriately reimbursed for the work that you do.
Correct.
And speaking of modifiers and questions that you get from the audience, Belle Marie says, we have a PA that does cath changes but does not charge for them. Instead, she added to medical decision making for the E&M code because she knows some payers don't pay the E&M with a catheter change. What do you recommend we do?
Well, the catheter change, I mean, the E&M with the catheter change is going to be a little bit, they're trying to bill for one or the other. Now, a catheter change, can you get reimbursed for that, Dr. Lynn?
Now, if it's part of an E&M,
Yeah.
then it's included.
Yeah.
And
So-
also the catheter change, so I just had one today.
Yeah.
An older guy who did not want to have a TURP. He would rather wear a catheter. There was no separately identifiable work that I was doing. I just had the medical assistant change out the catheter. So that's a straightforward loss leader, if you will.
Yeah.
So I supplied the catheter, the personnel, everything else needed to do the cath change, and the only code that we bill is a straightforward cath change.
Yeah. I mean, I think that if you're doing the E&M code, I think and not doing the cath change, you're doing one or the other. It is really a practice decision in that point. You can't bill both of them. So you're really just stuck doing one or the other. So if the PA, you would want to look at the reimbursement for those. We get that often with, should I do a nurse visit or should I do the service? And you really do have to look at that item. However, I will tell you, 99211 is a highly denied CPT code that require it, you'll end up sending records in if you do that. Sometimes they say it's too low of a level of service. So if they're looking at that and you're seeing that those are being pulled for records as well, you might want to just submit the cath change. That would be my suggestion.
Yeah, I think a lot of practices don't understand or don't realize that, like, say, a drug administration, there's that actual drug code, and also there's the administration code. Part of that administration code includes a small amount of evaluation and management, meaning before you administer the drug, you have to make sure the patient's okay, make sure he or she understands what she's about to go through. So that workup, that evaluation is part of the administration code for the generous payment.
Correct.
And I say that facetiously. Yeah, for the generous payment that you get for the administration. That administration code includes a small amount of the evaluation and management, unless you're doing something completely that you can easily identify that is separate and significant, then you should not be using a modifier 25 to pull that drug administration and use a 99211 in addition.
Yes. We have that conversation often, especially with Luprons and such. Why can't I just bill the E&M code? And we are coming back in audits and letting them know that it's not supported and why. But it is that you hit on that. It's the, one of my notes that I just made is, understanding revenue cycle and the assembly line and revenue cycle is really important for every single person that's in that in our space, whether you're the physician or you're the administration staff or you're the check-in, check-out eligibility person, authorization person. Understanding this from the start to finish is really important, because any of those missing steps equals delayed and or loss of income. And even, I want to stress, delays are a loss of income. A delay in any sort is costing your practice money. So anything that you guys can do to make sure, I stress this all the time. You guys are probably really tired of hearing me say this. This is from the start of the claim, your eligibility, making sure that your patient demographics is in the system correctly, that the authorization or referral that was needed was done and was complete, that you guys are putting in all of your CPT codes and adding your modifiers and linking to the right diagnosis codes. All of that work that you can do at the beginning to lessen the amount of return that claims that you have or denied claims on the back end are really going to help your practice. Just remember, if you don't get the right information, you have to bill the patient. That costs your practice money. If you guys get the no auth, it costs your practice money. If you guys don't check to see, you check that they're eligible for Medicare, but you don't see that they have a Medicare HMO replacement plan, cost your practice money. What I'm seeing, and I say this over and over again in this industry, is that lack of understanding of how that flows through the assembly line and how a claim resolves at the back end is costing a lot of practices money, and it's building up, and it's one claim after the other until a practice is struggling and you have, 40% of your aging at 120 days and over, and you're at the mercy of the payers to try to meet their timely filing deadlines.
That is sad to see when you see that happen, I'm sure.
It is something that I still don't, we want to help everybody. We understand the staffing shortages that are happening in practices, and that you're taking staff to go and place them in places where it's needed. But if you guys are not working your aging claims, your denied claims, you are losing money. It is just something that needs to be done. You need to pay attention to the claims that are coming back in to the system, and even more importantly, the responses that you're not getting from your payers. You need to call on those claims, because they could have sent you something that you may have missed, a correspondence that you didn't respond to. And if you then call them and they sent you something 6 months ago, you could be out of timely filing for that claim.
Yeah, let's see. Monique said, in reference to something that I'm sure you mentioned earlier, they don't have enough knowledge and just read from a script. I'm assuming that you're talking about, Monique is talking about the insurance companies, the folks from the insurance companies. They often just simply read from a script.
They are. And I think she's also talking about, billing companies that might have overseas staff as well. They are also reading from a script. We're really realizing that they're taking that black and white when they're this industry is not black and white. I hear that also from clients that we're talking to. This should be this way. You, like you said before, I shouldn't have to add a 59 modifier on there. However, we need to understand that Blue Cross Blue Shield does not have to follow CMS. So that CCI guideline that wouldn't need a 59 modifier may be needed for that commercial payer, and really trying to realize that it isn't black and white. And that is what a lot of the overseas products are, is black and white. And therefore you are going to have that. They said this, it needed this, this isn't here, so therefore it won't get paid. They're not thinking outside the box to say, okay, maybe I need to go back to Dr. Jones and say, hey, Dr. Jones, we got a denial for this claim. They're stating this doesn't support that. However, if we make an addendum, or if you want to get on a peer-to-peer, we could have you state your case. Those are the things, thinking outside the box, that may not happen from a lot of overseas billing companies. And also when you call the insurance company, pushing them past their book that they're reading from.
I'm hearing you say that there's a lot of nuance when it comes to coding and billing. The way I think of it is Medicare being the largest health insurance payer in the country. So you have Medicare and their rules. And then for the private payers, you have individual private payers with their own claims edits that you have to follow, if you will. And sometimes certain CPTs may not be paid by a certain payer, but another payer will pay for that CPT code. For instance, the prostate biopsy codes, the actual needle biopsy, the transrectal ultrasound, you used to be able to build 3 or 4 codes in the past, and now it's just a couple of codes. However, up until recently, some payers are still paying for the 3 or 4 codes.
That is a great example. That's a great example. And then you stop billing them all together, but actually half of your payers would have paid for the 76942 and the 76872. So really keeping track of, Mark always tells me, don't say always, never, those definite ones. Be willing to look beyond what's right in front of you and see if there's another way, another door to go through with a payer. It's important. I would love to say to you guys, don't bill an E&M with a cysto, because you're going to get the denial on the back. We're going to have to appeal, do them in separate visits. However, there's a clinical aspect of it that Mark, talks about, providers talk about. It's not feasible for the patients, really. It adds cost to them. It adds driving, all of those things. So now we need to appeal those things to fight that greater fight, and hopefully they overturn their decisions for doing that in the backside. But I just want to make sure, you guys, I hear a lot of definites in the billing and revenue cycle and coding world. It is not so. It is not black and white. And even, I'll give a great example. When I start a new employee in the revenue cycle in the AR department, and they want to get into the AR part where they're checking claim statuses, we start them with Medicare. Medicare is the most black and white. They've got little gray. They've got the most guardrails. So it's good to start them with that, because they can start with those guidelines. And then you can move them on to say, okay, now you go to Blue Cross Blue Shield and all that's blown out of the water. But that's a great way of looking at, hey, I start them there, because then they can learn the basics and the groundwork behind CMS and looking at CCI, and then go to all the and ifs, but, and all of that stuff. But really and truly making sure that it is not, if the claim is denied, there may be another way for you guys to get that paid. And don't be afraid to ask. And also, just because somebody gives you one answer, I'm going to give you another thing. We recently had a group with a contract that was very old. The provider had been, the original partner had been in practice for a very long time. Contract's older, and the contract had a set list of CPTs that would be paid. Well, when they started doing PAE in the practice, those CPT codes were not on that contract. So, because it was so old. So it was like, it should get paid, but what they really needed to do is go to that payer and say, hey, this is an old contract. We need to update these codes. But they said, okay, we're not going to do that for this payer anymore, because it won't get paid because it's not part of the contract. Really understanding that, hey, this was an old contract. This had a grouper that was a zero charge, but it's because that wasn't a CPT code back then, or it was just one that they didn't use in urology. So really looking outside that box and making sure that you guys aren't just saying, okay, I'm never going to do this again. Kind of just trying to reach out to people, keep asking on the Thriving Urology practice. I see a ton of stuff on there, resources that give people another idea, another pathway to go down.
Yeah, so one of the resources is the Thriving Urology Practice Facebook group, where we are live streaming right now with, gosh, how many people do we have watching? Over 30 people watching, which is pretty amazing for such a small Facebook group. Post the wins, post the nuances. A lot of us will post, hey, for instance, today I posted something about time-based billing. I saw a note from another practice saying, hey, total time spent was 40 minutes. Over 50% was spent on counseling and coordination of care. Well, those rules changed back in 2021.
Yes.
And yet you still have this person who works in the LUGPA still not knowing the rules, the actual rules as it exists in 2025. So education, sharing this information, so there you have Medicare, which is relatively as black and white as it gets, with lots of guidance and Medicare claims manual, etc. Then you have the 50 shades of gray when it comes to private insurance and private payers. So,
and realizing that Medicare replacement plans are not Medicare. I speak about this every single week, maybe sometimes every day. Please know that they can also have their own rules at that payer. It is not black and white there either. So they are not Medicare. While they may have some guidelines that they have to follow with CMS, they also can have their own guidelines. So you really just need to make sure that you are not just flat out applying, hey, this is a Medicare replacement plan, so they have to follow Medicare. They do. That is not always the case. There are things that they will have outside. They will have certain policies with United Healthcare replacement plans, Medicare replacement plans with Blue Cross. And so really making sure that you're saying there's Medicare, there's Medicaid, and then there's all these other buckets here that can fall outside or have similarities to Medicare, but different rules that may or may not make sense why they apply certain things on that payer's end.
Now, I understand that some of the patients cannot afford a Medicare and a supplement. So, and I'm really happy and pleased that you never said once that it is a Medicare Advantage plan. It's actually a Medicare Disadvantage plan for not just the provider or the physicians and the practices, but also for the patients for numerous reasons. But you have, I think everyone needs to understand that Medicare replacement plans or these Part C Medicare plans, they are not Medicare. They are a privately held company running some of the benefits while collecting money from Medicare. Once you sign up for one of these replacement plans or disadvantage plans, you are no longer on Medicare. So Correct. I think a lot of people don't quite understand that. The patients don't understand it. And I think a lot of the practices who bill for Medicare disadvantage plans, they don't understand that it is actually private insurance. When it comes to newer technology, even though Medicare may pay for it, if they don't have an LCD or NCD, National Coverage Determination or local coverage determination, some of these Medicare Advantage plans will say, hey, there's no actual NCD, LCD. We can make up our own rules when it comes to some of the newer technology. So just because Medicare pays for it doesn't mean that Medicare replacement plans will follow suit.
Correct. And really stressing on that is that exactly what you just said. It does not mean that they are going to have to cover it or that you're going to get them to cover it because you bypass that authorization piece. And all on that, I think that you are very correct. This is one of the top 3 items that I see when we're going into practices is this Medicare replacement plan issue. Remembering that your systems, you guys, the eligibility systems that are with almost all of your practice management systems, if the patient is eligible for Medicare and had Medicare but chose to have a replacement plan, they're going to come up eligible with the green check mark or the eligible or the accepted in your practice management system. Please look past every Medicare patient and look into the details of that eligibility. Please go in and look to see if it says other primary benefits, other payer is primary. You look past that because what we're seeing hundreds of thousands of dollars of loss in is exactly that. You're going through your system, the person's doing the eligibility, all the Medicare says accepted, and you proceed on with the visit as if they have Medicare. The doctor now wants an injection or a procedure. Surgery scheduler, whoever looks at it, says, oh, they have Medicare. I don't need an authorization. You schedule them, and then that procedure or injection gets done even within the next week before a denial comes back. And now you're out that injection or that procedure because it needed an authorization because they had United Healthcare Medicare replacement plan. I cannot tell you how often I'm writing document after document. We're doing recorded videos for people on how to do the eligibility. This is very, very important for your staff to understand that the Medicare replacement plan is replacing Medicare's benefit. However, it has its own rules, its own authorization requirements, its own formularies for the drugs. It may not be covered. And if you see that patient and you think they have Medicare and you pass them through, it is most likely going to be a complete loss to your practice, because once you need an auth, as we all know, the payers are not doing retro auths. And by the time you find out from Medicare that it's on a replacement plan, it is almost too late to do an authorization for any payer that you have now.
Yeah. So you're saying that look beyond Medicare eligible on
Yes.
your practice management system that does automatic benefits verification. Look beyond that and make sure the patient truly
Yes.
has traditional Medicare and not one of the replacement plans. And
Yes.
Shalina said several payers have their own procedure coding edit tools on their portals that are a helpful tool to utilize when getting a bundling denial that does not match NCCI.
Yes, that is true. The portals, Shalina, thank you for saying that. The portals are getting more advanced every day. You guys can put in all codes that you have billed and it'll tell you what is needed. So if you get something back from that payer that says it's denied for bundled, you can go place it on there and it'll actually let you know why it's bundled and why it doesn't pay a lot of times. And you can know that you need to add a X modifier or a 59 modifier. Oftentimes you'll know right away that it's never going to pay. It is going to be unbundled, so you can avoid from billing it at the beginning. I think that it's more important that we start really focusing on that in further discussions, is that many doctors are paid off RVUs. And when we overinflate that in the systems, if we're putting in codes that have an RVU value that aren't going to get paid, we really need to start focusing on the administrative side on which one we should actually be placing in the system if those providers are getting paid on that, because it's hard to back them out on the back end because we're writing them off and that RVU value still goes to that provider. So when we're really balancing all those things out, what they should be billing and getting paid for, and then making sure that if they're not going to get paid for something ever on that contract, it doesn't go into the system is just as important as well.
Boy, that's a different level of headache, because
Yeah.
what I'm hearing you say is that if a doctor is paid by RVUs and the RVU is credited to the doctor, yet the practice doesn't get paid actually dollars for the RVU that the doctor got credit for, then the practice is actually losing money.
Correct. There's bigger things. That's why I said understanding RCM as a full, and not just the the people who are doing your AR, but your administrators as well. Really trying to see how that's all set up, how you can use your system better for the edits, the claim scrub edits, to make sure that those things pop out of the system that you don't want to have billed, that may always deny, how you can use that to help the administrative side as well. It is very important to understand that fully, because we're seeing these things change, and it's just as important for the doctors to get every RVU in there that they should be paid for. But if it's not getting paid on the practice, really coming back and saying, how do I fix that so it's not costing the practice money as well?
Okay, I have a question from Lucinda, who said, any solution for United Healthcare dual policies and Medicaid secondary non-payments? Do you understand that question?
Yeah, the dual policies are pretty much like Medi policies. They are a Medicare, Medicaid product, and they don't end up paying because they're telling you this policy is primary. No, this policy is primary. What we've done with those is phone calls to the payer and writing letters to the payer stating, we've had these claims. You're not paying these claims. This patient has a dual complete plan that has been verified. We've been sending in the eligibility with that. the confirmation of the eligibility, and then we've been following up. It may take a little bit of time, but we've been able to turn a couple of practices around where they've actually updated their system for that provider, and now they're pushing those claims through. I think they're confused on the other end, and specifically United Healthcare. I think they're not being able to identify which one should pay as primary, even though they know it's the Medicare product, but keep pushing on those and send the eligibility. That would be one that I would do an appeal for.
There we go. Knowing appeal, correction,
Yes.
and reconsideration, knowing the
Because
difference.
you
So
can't correct the claim. You don't want to just keep pushing rebill to send the reconsideration. That would be an appeal, pleading your story to say, listen here, I've had this claim out to you for 6 months. This patient has this policy. And then if all else fails, turn the patient on them. Have the patient call the insurance.
having the patients advocate on your behalf to make sure the claim is paid is really, really powerful.
Yes.
Also, reaching out to because a lot of the private payers are being paid by the employers of the patient or of the patient who's an employee, often contacting that HR person or having the patient contact his or her HR, because HR has the power to say we want to continue contracting with the insurer or not. So I think engaging the patient sometimes is going to be very, very helpful.
Correct. And, on that Humana subject that we talked about right at the beginning, that's what I'd like to tell you guys all. I'd like to tell all the practices, hey, tell the patients, hey, Humana's not paying our claims and down coding, give them a call. And let them know this. We've got to limit the amount of Humana. I wish I could say everybody, limit your practice with Humana, but I know how the burden is on there. But if we could get the patients involved, we do see a better outcome as well. So if you guys can't get that done, telling that patient, by the way, I can't get your claim paid. Can you please call your payer and your insurance right now and help us out? They respond to the patients very quickly. We all know, if anybody's worked in the AR, we've all gotten on that phone call from the insurance company with the patient on the phone with the insurance company because they're saying that the claim was not coded correctly, or if you just do this or you just do that. But we've all been on those phone calls. They do act fast.
And I want to encourage everyone or empower you, those practices that can. I understand that some of the larger practices, they cannot eliminate some of the payers or any of the payers, but for the smaller practices, you have the power to say no to a lot of payers. And you'll be amazed. Ask me how I know. You'll be amazed how few payers you need to run a very profitable, sustainable, happy practice for you and your staff and the patients. So saying no is a superpower that everyone should consider using.
That's one of my this year's goals, is saying no more. So I am practicing that. But you're touching on one of the things we should just talk about real quickly before we're all done here is you speak about it a lot. The amount your patient is becoming a high on your payer mix. In a lot of practices, it's number 1, 2, or 3 in some practices, depending on, what your cases are and what your volume is. But your patient responsibility in collecting that is so, so important. And, we're talking about the patients advocating for the insurance companies, but also making sure you guys realize, we saw a claim the other day. Patient was seen for a level 3 and a UA, and the patient had a $95 copay that wasn't collected and had already been sent to collections. So I just want to make sure you guys are realizing that $95 is probably going to cover that entire visit. And so if you don't collect it, that provider just saw that patient for free. And we are seeing higher and higher copays, higher and higher deductibles. We're faced with, looking at plans with higher deductibles all the time each year when we're renewing. Just make sure you guys are having a policy to collect those copays and those co-insurances if you can. And when you have deductibles at the beginning of the year, and if they have past due balances when they come back for your visit, make a plan to collect it then. No time like the present when they need you guys into practice, because once you guys are not a need for them, those balances may not get paid. And I know this firsthand because we're sending thousands and thousands of claims to, patients to collections every year for multiple clients. And a lot of that is for copays.
Have you noticed any changes recently with the number of people that you have to send to collections?
Yes.
It's
increasing.
is increasing.
Yes.
Okay, that matches with despite what Jerome Powell is doing by not decreasing interest rates. Now we're talking macroeconomics now. First of all, the delay in one's ability to pay, in one's ability to not pay the tuition, the student loans, that's gone away. The 60 to 90 days, the 30 to 60 day delinquency for student loans is going up. Despite what Jerome Powell is not willing to do, all the softer indicators are, we have massive layoffs, unemployment's going up. The softer indicators are showing that economic times are not as easy as before. Everything, the price for everything is going up except what physicians get paid. Everything is going up, and yet wages have not kept up.
Yeah.
Patients are just like you and I. We will pay for a roof over our head, maybe cell phone, probably.
Yeah. Oh, always a cell phone.
Cable, of course.
Yeah.
And I got to get my manicure, right?
Yep.
Mani and pedi. But the last person they'll pay is probably the doc.
Yes.
And what you said is so true. You have to figure out what the patient responsibility is at the time of service. Have someone who is comfortable at the front lines in collecting that payment. And if he or she is not comfortable in collecting those payments, he or she needs to be assigned somewhere else or possibly another practice. You cannot in 2025, actually prior to 25, you can no longer just say, we'll collect it later. We'll bill you for it. That is not going to work. Your practice will tank.
It will.
Go ahead.
And again, like I said, that you didn't collect it then, and now you're spending more money to collect it because you're sending out statements, you're having phone calls being made, you're having to send to collections and review a report that comes in every single month, or post the $5 that they pay the collection agency back into your system every month. It costs money when you don't collect that. And in turn, the number of practices that continue to see patients that have already been sent to collections is another thing that needs to be handled. Those, like you just said, that front desk person needs to know how to say that. Don't say, can you pay? How are you going to pay this? How are you going to pay your copay today? The minute you say can, will, you're giving that person on the other end a decision, a choice. And of course, they're going to be like, I don't want to pay this right now. I want to keep my $60. So making sure that you really do have that person on that front desk that knows that, and you have a steady, very, very black and white, as we were talking about, policy for that front desk person, that check-in person to follow, that states what they're supposed to look at. They're supposed to look to make sure, double check that patient's eligible. What is their copay? Do they have a past due balance? And further on to that, we've talked about in past ones, is that pre-visit. If you guys have that pre-visit person who's looking at charts ahead of time, for 3 days ahead of time, who can maybe call that patient ahead and make that payment plan or get that payment for the past due balance ahead, that takes that burden off that front desk.
Yeah, we just hired someone new, replaced someone for benefits verification. So Naomi is just starting out doing exactly what you said. Determining benefits, determining the copay, unmet deductible, co-insurance, etc., before the patient gets here. And also for the recurring patient, the follow-up patient, consider credit card on file. So to decrease the friction or the burden for the patient to satisfy their debt requirement to your practice. For the last several years now, the largest payer in my practice is not Blue Cross, United, Medicare, Aetna, Cigna. It's what patient actually pays us. Now, my practice may be different than others. We may do more. We may collect a little bit more cash because of some of the services that we provide that are not covered by insurance. But that is how big of a bucket it is for a small practice like mine. So imagine how much other practices are losing if they're larger and then if they're not doing this.
Correct. And look at the ROI. We hear often, I can't afford to have another person to staff another person. If you guys take the amount of money that you're spending, that you're turning over monthly or quarterly to collections and not collecting, and look at what that salary would be for that employee, you guys can afford that. It is I'm telling you, if you look at that, you will see that if you just had that extra step, that pre-visit, or that educated person who can collect that money at the beginning, at that visit, you guys will see. If you guys take your balances that are due from patients and you sort them from highest to lowest, you'll be able to see, I do it often, 10, 20, 15, 25, 30, 35, anything that's probably under $100 was most likely pretty much a copay.
And I'll read a comment from Tanya, very, very salient point. She said, it is so important to collect whatever is due prior to the visit because now many times in many states, the balance due is not going to be reported to the patient's credit reporting agency. So really, what is the motivation for the patient to pay you after the fact?
Correct.
Great point. And
Yes.
Heather said, front desk knowledge is super important. First line of defense and first impression. That is so true. Not only is it first line of defense, it is first impression. And Tanya said, I worked for a gastroenterology clinic. They sent a letter to the patient 7 days prior to their visit to let them know what their copay would be or deductible may be and what their estimated cost would be after the procedure with options to pay prior to the visit. That's a great way to go about it. What we do is we have someone contact the patient and text the patient or text the patient the amount that is due to the practice before they come to see us. So they will have some form of payment to us. And like you said, Marianne, it is not would you like to pay or can you pay? It's how you would like to pay today.
Correct. We were at a clinic not too long ago and we heard this over and over again. And as soon as they gave that, they're like, well, I don't have my debit card. I'll bring it back in here. And so you did have that hem and hawing. And it was more than 6 times that I heard that during the couple hours I was up there. And as soon as we were talking to them and I said, hey, next time, maybe what you want to do is state, Mr. Jones, you have a $20 copay. How are you going to pay that today? They don't stop. Usually, maybe some of them will hesitate, but most of them are like, okay, here, they just give you your debit card. It's exactly what happens at the grocery store. When I go up to the self-checkout, I know I'm going to scan my stuff and I don't just run out of the grocery store. I have to pay and put my debit card in there. If the machine said, hey, do you want to pay for this? I would probably say no and walk out. So it is kind of that scenario and saying that you really do want to collect what's due, really have those policies in place. And I know all my staff that's here listening to that is here, we deal with the back end of that process, whether we're on the phones making payment plans for people who owe $60 or we're sitting there and we're having to bill those over to the patients or we're making collection lists at the end. It is discouraging to us because we're also hearing the providers say they're not making enough money. We're dealing with the practices on how they make more money. This is a key piece of this, not just that eligibility authorization piece. We're always talking this collection of patient responsibility is really, really, really important. And really, let me just stress to you more importantly, when you bill a patient for that copay, and let's just say then they get that bill, they often call us and say, why wasn't that collected at the time of service? And so it's just a reflection, exactly what Tanya was saying. It's a reflection on your practice. If you set that standard that this is due, this is how your practice runs, you're efficient, the doctor's efficient, your billing's efficient, everything's efficient, you're going to get those good reviews as well because it starts right there. And when they start getting billing statements and they start owing balances and they start getting that's when they're going to complain. So they could have gotten the best service ever from the provider and then they got a bill that they weren't expecting or that they didn't want to pay, and certainly now you've become the worst visit that they've ever had, and they're going to put that on the review. And we hear that on the side of our phone department. It really is where you could do everything right, but they got a bill that they weren't expecting, and they will make sure they tell you about it.
Yeah, reviews are mostly about time, money, and level of service.
Yes.
That is so important. Linda said, patients are more likely to pay prior to fixing the problems. If they are in pain, they will find a way to pay it. That is exactly right. And Heather said, will that be cash or credit? And I would add, would that be cryptocurrency or other favors?
Yes, other favors. We did get one letter one time and the guy offered to pay the doctor in bracelets. So, hey. he didn't have any money, but we just really want to make sure that you guys, everybody out there is getting the money that they're due, and that we're not having any more issues with, we want the urology practices to survive, and that is really putting in a fine oiled machine, and making sure that you guys have all those pieces of that machine working and well greased and oiled. And a big part of that is revenue cycle. And if you don't understand your revenue cycle, and you don't understand what revenue cycle is, then you come ask questions to everybody, the Thriving Urology practice. If you don't know how your billing department is doing, if you have any questions on your AR and what that looks at, reach out to people, ask on this network, ask the community, because if you're not understanding, most likely there's something that can be done to improve your revenue.
Oh, wow. As always, amazing insights on what exactly is going on today.
Yes.
And what is happening out in the country, not just in your own little practice, but what's around the country, what is actually happening. Always tons of fire, tons of insights from you, Marianne. Thank you so much. I really appreciate it.
You're very welcome.
Let's see if there are any last minute questions. And of course, there are last minute questions and comments. Linda said patients, let's see. Oh, nope, I already read that. Tanya said, we had a patient in our gastroenterology clinic that offered to give free Chinese food for a year to the doctors.
Hey,
sign me up.
I know. I was going to say, Dr. Lynn, that's you. Your poke bowls.
Oh my! Yeah, the poke bowls, the
poke bowls. Yes.
Yeah, the sashimi and the rice bowls.
Yes.
Well,
it's been fun.
I'll let you provide any final thoughts.
Just want to make sure you guys, like I said, just keep asking questions. I love seeing the discussions that happen and the people jumping in. That's encouraging to me. It means that, hey, people aren't afraid to jump in. And then when somebody gives some different input, just keep asking questions. That is how we are going to help each other as a community, and how we're going to keep succeeding, and how we're going to make sure that the urology practices survive.
Marianne, thank you again.
You're welcome.
All right. For those of you, thank you. First of all, thank you so much for all the comments and the emojis. And shout out to, Rhonda Menchie. Now, notably, Rhonda had no urology coding and billing experience, and she's self-taught. And through the Thriving Urology Practice Facebook group, I met her in person at the most recent Urology Advanced Coding and Reimbursement Seminar. You can teach yourself this information. You can gather this knowledge through participating in this Facebook group, attending meetings. And again, I highly encourage you all to consider attending the Urology Advanced Coding and Reimbursement Seminar in December this year, and also January 2026. And the reason that these are held in December and January is because Medicare, again, the largest payer in the country, changes rules every year. Typically the rules come out, the final rule comes out at the end of October, beginning of November. What we'll do is interpret the rules and the changes and share that information with you at these Urology Advanced Coding and Reimbursement seminars. Those practices that learn these rules right away and implement it in 2026 will benefit the most. Just like prior procedures, initially, it paid really well. It was easy to be paid. But then over time, Medicare ratchets down on payment, making it much more difficult, and the payment decreases. Most recent example will be Urolift. Initially, it was paid really, really well, but then over time, the payment decreased, and then they have the medically unlikely edits and things like that. So the knowledgeable folks, the knowledgeable practices benefit the most. And if you are a little bit late to the game, then you may have a harder time and you may miss out. And that is why you should consider attending these courses, because you will get firsthand, up-to-date knowledge that changes every single year. And that's why it's done. The meetings are held in December and January, so that you have the most amount of time throughout 2026 next year to implement these rules, so your practice will continue to thrive and succeed. Because urology practices, we have taken a cut every single year when you adjust it for inflation over the last 20 years. It is not going to be sustainable unless you run a profitable and efficient practice. What Marianne shared with us today is freaking invaluable. And thank you so much, all these folks in the comments praises enjoyed tonight. Thank you. Really, really appreciate you for attending. And once again, thank you to Marianne. As always, thank you so much for the privilege of your time. Please take care of yourself and each other. Until next time, bye-bye.